Trigger finger, or stenosing flexor tenosynovitis, is a common hand condition that affects the movement of the fingers. It occurs when there is inflammation and narrowing of the A1 pulley, which is part of the tendon sheath that helps the flexor tendon glide smoothly. When this pulley becomes thickened or swollen, the tendon cannot move freely. As a result, the finger may click, catch, or lock when trying to bend or straighten it. The condition is most common in women aged 50 to 60 years and also in people with diabetes. The ring finger and thumb of the dominant hand are most frequently affected. The name trigger finger comes from the way the finger suddenly straightens with a snap, like pulling and releasing a trigger. There are several causes and contributing factors that lead to trigger finger. The main ones involve repetitive strain, compression, and systemic diseases. Repetitive finger movements. Continuous gripping, squeezing, or bending of the fingers can irritate the tendon sheath. Examples include typing, knitting, playing musical instruments, and manual work such as farming. These repetitive actions cause friction and inflammation, leading to thickening of the A1 pulley. Compressive forces at the A1 pulley. Using tools like scissors, pliers, shovels, or screwdrivers places direct pressure on the tendon sheath. Systemic conditions. Diabetes mellitus and carpal tunnel syndrome are strongly associated with trigger finger. In diabetic patients, high blood sugar causes the tendon and sheath to thicken. Occupational overuse. Repetitive or forceful hand movements performed for long hours without adequate rest. Over time, this repeated friction and strain can cause the tendon sheath to become irritated and inflamed. Clinical features are signs and symptoms. The symptoms of trigger finger usually develop gradually. At first, the person might only notice painless clicking during finger movement. Over time, the condition can progress to painful catching or locking when bending or straightening the finger. Common clinical features include: finger may unlock with a snap or remain stuck in flexion. Loss of full flexion or extension as the condition worsens. In severe cases, may require manual assistance to extend. Chronic cases can lead to PIP joint contracture and stiffness. Doctors' management for trigger finger focuses on reducing inflammation, relieving pain, and restoring normal tendon gliding. Treatment usually starts with conservative management, and if it fails, then surgical treatment is considered. Activity modification to reduce repetitive strain. Nonsteroidal anti-inflammatory, NSAIDs, for pain control. MCP joint immobilization or splinting. A splint can be used to rest the affected finger in a neutral position. It prevents excessive bending, allowing the tendon to recover, typically worn at night or during activities for 4 to 6 weeks. This reduces inflammation and allows smooth tendon movements. Corticosteroid injection. If symptoms persist, doctors may inject corticosteroids around the tendon sheath. Trigger finger release surgery is recommended for patients who continue to experience triggering of the finger or thumb, even after they have undergone therapy and steroid injection. The tendons of the finger flexor muscles glide in a tunnel which consists of 5 pulleys. The pulley at the base of the finger becomes inflamed and swollen, making it hard for the tendon to glide smoothly through the pulley. This results in the pain or catching feeling when you try to flex your finger. A trigger finger surgery is done to increase the space for your tendon to glide freely again. First, your surgeon numbs the area by injecting a local anesthesia into your hand. Your hand will then be disinfected. Your surgeon will make an incision of about 1 centimeter in your palm where the swollen pulley is located. Next, the surgeon cuts the pulleys that impede the finger movement. The complete release of your tendons will be verified in 3 ways. First, by opening up a pair of scissors on top of the tendons. Second, by pulling on the tendons with a tendon hook. Lastly, your surgeon will then ask you to flex and extend your finger to fully verify the releases. Finally, the incision is closed with sutures and a compression bandage applied. Physiotherapy plays a vital role in trigger finger management, especially to reduce pain, improve range of motion, and prevent recurrence. Contrast bath, 15 minutes. This involves alternating immersion of the hand in warm and cold water. Joint mobilization. Gentle anterior, posterior and posterior anterior glides, grade 2, at the middle interphalangeal joint help maintain joint mobility. Tendon gliding exercises. A1 pulley stretch technique. Combination of active flexor contraction and examiner resistance to stretch the pulley and break adhesions.